This lecture will look at some important gram-negative bacilli that are human pathogens. The objectives remain the same as previous lectures, but in this lecture we'll focus on the gram-negative bacilli. So let's jump straight into our first case, a 3-year-old child who presents with bloody diarrhea for a week and easy bruising. On examination, on investigation, she has renal failure and a hemolytic anemia with thrombocytopenia. Stop the video, see if you could figure out what syndrome is this and what is the likely organism, and then you can maybe think about the characteristics of that organism. So this is a patient with hemolytic uremic syndrome, and this is an autoimmune condition that can be precipitated by infection with Escherichia coli or E. coli. The organism is a gram-negative aerobic bacillus, which may or may not be encapsulated and is flagellated and motile. It's a lactose fermenter. It is a normal gut commensal but can cause disease, and virulence factors include several enterotoxins, plasmids, which can vary the bacteria's genetic makeup and make them evasive to normal antibiotic therapy, and can also be useful in promoting virulence. The Shaker toxin is a specific toxin produced by the bacterium, which is responsible for some of its autoimmune manifestations, such as hemolytic uremic syndrome. Clinically, this bacterium can cause dysentery, bloody diarrhea, and is a common cause of urinary tract infections. Specific strains of the bacteria can cause hemolytic uremic syndrome, and we do recognize two different pathogenic strains that can cause more severe disease: enteroinvasive E. coli and enterotoxic E. coli. Females are susceptible to UTIs from E. coli really because of the proximity of the urethra to the anus and the perineum and the shortness of the urethra in the female. Young children up to the age of about 4 are also susceptible to hemolytic uremic syndrome. We've listed some of the antibiotics that can be used to treat this condition. The diarrheal disease treatment is mostly supportive, as is HUS. And this is just a picture of E. coli. It's just a gram-negative bacillus on microscopy. Here's a second patient, a 58-year-old alcoholic who presents coughing up red jelly-like sputum. And when we look at the X-ray, it's an upper lobe pneumonia with some bowing of the horizontal fissure. Pause the video and answer the questions. This is Klebsiella pneumoniae. It's a gram-negative encapsulated non-motile bacillus, which is aerobic, although it can survive in anaerobic conditions, and again is a lactose fermenter. It has certain virulence factors, both in terms of adhesion to host cells, pro-inflammatory molecules, and immune avoidance through its capsule and biofilm. It actually has a fairly thick capsule, gelatinous capsule. It can cause urinary infections, pneumonia, and wound infections, particularly in immunocompromised hosts. Alcoholics, diabetics, and patients on chemotherapy are particularly susceptible. Supportive treatment is essential in these patients, but there are some antibiotics that are preferred as listed. This organism has a high level of antibiotic resistance, so usually we use multiple antibiotic regimes to avoid this. Here's a picture of Klebsiella, and as you can see, each organism is surrounded by a fairly thick capsule, which is one of the hallmarks of the organism. Case 3 is a 32-year-old female Discharged from hospital after being treated for extensive burns. The wound is now red and painful and is oozing green pus. And here we have the wound with an eschar and some greenish pus around the edge. Pause the video, think about the likely organism and its characteristics. This is Pseudomonas. It's a gram-negative encapsulated organism which also forms a fairly robust biofilm around the bacterial colonies, which is protective. It's aerobic and non-fermenting. The organism produces has flagellae and fimbriae, which allows for adhesion onto tissues, host tissues. It also secretes proteases, endotoxins, and pigments, which can cause cellular damage and spread of the organism, and it can be protected by a fairly robust biofilm as well. It's responsible for nosocomial infections of the lung, urinary tract, and skin, and is a particular problem with burns patients. Cystic fibrosis patients are also prone to infection with Pseudomonas, lung infections with Pseudomonas. Other susceptible groups include hospitalized patients, patients on ventilators, and diabetics. Surgical debridement is an important part of the treatment of this condition, but multiple antibiotics are often necessary to get rid of the organism, and there is a high degree of resistance to antibiotics. Here is a picture of Pseudomonas, pretty fuzzy picture, but these organisms also have a prominent capsule as well, not as easy to see on this picture. The fourth case is a 2-year-old with fever, abdominal pain, and bloody diarrhea. His siblings have had similar diarrheal and febrile illnesses, as has his father. Stop the video and see if you can figure out what's going on here. This is shigellosis, or bacterial dysentery. It's caused by various Shigella species, and these are non-motile, gram-negative, non-encapsulated bacteria. Some of them may be encapsulated, but in general they're non-encapsulated. There are 4 serogroups, or 4 species. Dysentery causes the most severe illness. It's aerobic, but can live in anaerobic conditions, and it's a non-lactose fermenter. The bacteria can invade the mucosa, and some of the toxins also lead to cell deaths, leading to the bloody diarrhea. The Shiga toxin is a secretogog which promotes diarrhea, which can be profuse. So the organism causes dysentery, and as a complication of the dysentery, particularly in younger children, you may have HUS developing. Susceptible hosts include young children, the immunocompromised, travelers, so it's a cause of travelers' diarrhea, and men who have sex with men. Supportive care is essential, particularly with regard to hydration. The first-line antibiotic of choice is ciprofloxacin, and these patients often end up with chronic diarrhea, and a low-fiber diet may reduce the duration of these symptoms. And here's a stool smear showing these rods in the middle are Shigella. Case 5 is a 76-year-old male patient with diverticulosis who comes in with an acute flare-up and is found to have a pericolic abscess. Stop the video and think about what organism might be involved. So that case is a little bit of a setup, because the organism will not only be Bacteroides, but it's just to remind you that the multi-organism infection that causes intra-abdominal abscesses, which would include things like Staph aureus, some other gram-negative bacteria, will also often include Bacteroides, which is a gram-negative bacillus. Although the shape of the bacillus is very variable, it's pleomorphic, and it is encapsulated. It's an obligate anaerobe and a normal gut commensal. It can adhere to mucosal surfaces due to its fimbriae, and some specific strains, such as enterotoxigenic B. fragilis, can cause quite severe diarrhea as well. It does, so it's a normal gut commensal, but when it invades the gut, it can cause intra-abdominal abscesses. It's often found in patients with intra-abdominal abscesses. Susceptible populations include older patients, those with chronic intestinal disease, and patients who have been hospitalized or had recent abdominal surgery. Because it forms abscesses, surgical intervention is often necessary, and we've listed some of the common antibiotics used in this infection. Here's a picture of B. fragilis. There are some other gram-negative bacilli you need to know a little bit about, and they're listed here. I think you should stop the video, make a note of these, and actually do a little bit of reading on each of these organisms. If there are any questions, you can bring them up in class. In summary, we've looked at all gram-negative bacilli as listed below, plus a few additional ones that I'd like you to read upon. Thank you.